This is Mike Levitt. Our nation is faced with two very important, but sometimes competing priorities. We have a duty to provide the best possible health care for every patient, but we must also remain competitive in a global marketplace. That's what value-based care is all about. Our challenge is to create a uniquely American system of health care. Truly, we're in a race to make value work.
Welcome to The Race to Value, a weekly podcast hosted by Dr. Eric Weaver of the Institute for Advancing Health Value. The Institute is a nonprofit organization focused on accelerating the industry to succeed in health value. Join Eric as they engage the executives, clinicians, and entrepreneurs who are leading this race to value.
Race to Value listeners, we have a return guest this week, Debbie Welle-Powell. She was previously on episode 154, Climbing the Mountain, Reaching New Heights for a Transformative Future. She is back to talk about how do we empower health literacy by thinking about information as a new social determinant of health. This is a completely new way of thinking about how we approach SDOH in the clinical care environment. It spans precision medicine, personal accountability, behavior change, and system level change that's needed. Debbie is such an incredible leader in healthcare. She's a 30-year healthcare executive veteran. She's in her career focused on delivering affordable and accessible high-quality care. She's out there providing thought leadership, education. She's a content expert. She's spent a career in developing innovative clinical models of care, population health, implementing telemedicine. She's currently active in her consulting work. Definitely someone who we always love to have on the Race to Value, and it's my pleasure to bring you Debbie Welle-Powell as she rejoins us this week in the Race to Value. Well, Debbie, welcome back to the Race to Value. It's been a few months. You were on episode 154. By the way, listeners, you have to check out that episode, Climbing the Mountain, Reaching New Heights for a Transformative Future. You know, Debbie, you talked about everything that I could think of in terms of population health and the value-based care movement, all the great work that you've done in your career. And now I have the opportunity to have you back on the show. We're going to be talking about this important piece of thought leadership that you've written around information as a new social determinant of health. And I guess before we get started on that topic, I just wanted to ask you, what have you been up to since we last talked?
Well, Eric, it is good to be with you again. I always enjoy our conversations, and I'm sure this will be similar to the past, engaging, and you always seem to come super prepared, and you're kind to your guests. And so I just really appreciate being here today and being able to talk about a topic that I care passionately about. But what have I been up to since the last time we talked? I have been teaching at the University of Colorado, a business school on population health. I've been speaking and moderating conferences and writing articles. That's what I've been up to.
Well, and we talked last time about this journey that you've had in your life with mountain climbing, and you've conquered so many summits. Have you climbed anything recently?
So I did go to Everest Base Camp, which was a trek that I had been doing for a while, and it continued to get postponed because of COVID. So in April, I did do that trek, and it was super fun. As you mentioned, I like to climb mountains for fun, and it was just so rewarding to be in the Himalayas. They have some of the biggest peaks in the world. And so I got to trek to base camp and spend a couple nights there, and just be a groupie among all those climbers that, have this pursuit to get to the summit of the highest mountain in the world.
Well, I think here at the Race to Value, we're groupies, for all the work that you've done, and you're such an inspiration, not only in population health, but how you live your life, your chase and conquering those great summits. And we have quite a summit to overcome in achieving population health. And for our listeners out there, we're all dealing with this aspect of social determinants of health. The 80% of a person's health and well-being that lies outside of the healthcare system, things like education level, stable housing, access to reliable transportation, food security, and a sense of community where you live, eat, work, pray, and play. And there's a gap in the current list of social determinants of health that you've written about. That's really this influence of information or an information ecosystem on patient behavior and engagement and health outcomes. And, I just have to think, despite us living in this super age where information is seemingly ubiquitous, the majority of citizens are in a bubble when it comes to accessing reliable information that can empower better health outcomes. It's either that or the countervailing influences of society leading to behaviors that lead to poor lifestyle choices that are simply too powerful to overcome. And information really is that ultimate enabler of health. But, a patient has to be motivated to seek that information and then take the appropriate actions to improve their health. And, with that in mind, you've posited that we should, as healthcare leaders, consider information as another social determinant of health, since it can be used to drive positive patient health outcomes. And a health system that recognizes information as a social determinant understands its pivotal role in shaping individual and community well-being. And by addressing information disparities and ensuring equitable access to health-related knowledge, we can promote those healthier behaviors and reduce inequalities and improve overall population health. So Debbie, I wanted to just, as we start our conversation today, ask you about how do you define this concept of information as a social determinant of health, and why is it important to include it in our list of things that influence health and well-being outside of the traditional healthcare system?
Well, that is a great question. About a year ago, I was listening to a medical director of Google, their medical lead, and I was at an NCQA's quality talk, and he kind of planted this seed in my mind around information. And I really began to think about, as you mentioned, all of the information that we have out there. And in fact, we have an overabundance of information, and it's not always accessible or reliable or scientifically based like we saw with COVID. And so I started thinking about, information really only matters if it helps the patient think about motivating them to change his or her behavior. And so this sort of how is information delivered, where we deliver it, and who delivers it is so crucial to empowering our patients to think about taking action differently than they do today. And then I started looking at really the evidence of where we are today. And this, we're like a $4.3 trillion healthcare system. We are the most expensive. We know that. We're 60th in mortality. We spend $12,900 a year. It's 18.3% of our GDP. And only 3% is really directed toward wellness. And so when you take a step back from that and you get on the balcony, you start to think, what is not really working? We say we're patient-centric, but I don't actually think we're as patient-centric as we say we are, because the information that we deliver to the patient or the consumer or the member or the subscriber is what really matters. And so I say that if it doesn't motivate the patient to change his or her behavior, then it's not the right information. So how do we think about the role of the clinician, the role of the delivery system, even the role of the individual, which I think is the most underutilized resource we have in the healthcare system, to think differently, to take action on their behavior. So there's a lot to really unpack with that, from health literacy to, again, the role of the clinician and what happens in that 20-minute appointment, to what the delivery system can do to support the clinician who supports the care team, who touches that patient. So we talk a lot about inpatient engagement. Yet, so here's some things, you probably know this, Eric, but the CDC reports that between 20 to 30% of our patients don't pick up their scripts. Now, there might be, there's a lot there that might influence one's ability to afford those scripts and find them easy to access. And then we also have, 30 to 40% of our patients are not following up on a referral to the provider. And so when you start thinking about non-compliance and you start asking the question with the delivery system, what is it that we need to know that we don't know to connect the dots, to engage patients, to find ways in which to get them the care that they need? I also mentioned in my article, think about this, if we're going to really meet the patient where the patient is, then how are we dealing with the patient at 2 a.m. in the morning? Patient calls in to a nurse care line. Are we able to really understand all of the social and personal types of information that, if it's a parent, might need? Single parent, child is sick, either first line is to think about going to the ER or urgent care. And to me, some of those activities are system failures to think, how can we meet that patient, that parent differently, so it's not getting into a car and driving to the ER, but really finding helpful information, whether it's an ear infection or having an otoscope, at home to say, did you look into the child's ear? Is it, red? No, I'm sort of simplifying some of this stuff. But how do we, whether it is 2 a.m. or 2 p.m., beyond our four walls, how do we engage with patients to meet them where they're at so they're getting reliable, accessible, understandable information that they can take action versus the action of, I'm not sure what to do. And of course, sometimes it's important to get in that car and go to the urgent care or go to the ER. So there's a lot to unpack with information.
Debbie, as you're talking, I couldn't help but think about the importance of the provider-patient relationship. Some of the examples that you provided, like 20 to 30% of patients not picking up their scripts, or 30 to 40% not following up on referrals, or accessing the ER urgent care when they could go to a primary care appointment to get their issues resolved. And it seems like it really does come down to knowing who to ask to get the information that you need to make an informed decision. And I can't help but think back about a formative experience that I had in my career. And it was just a trip that I took to Cuba. It was like a healthcare research delegation with a bunch of doctors and administrators. And they had a very high touch, community-based healthcare system. Now, granted, it's a third world country. It's not an apples to apples comparison, but the physician was very much treated like, if you've seen The Godfather, the role of Robert Duvall as the consigliere. He's the person that comes to the house for dinner, when your child's having some problems, and, he's a counselor, and the primary care physician actually accompanies the patient to the specialty referral. There's a very relational aspect to this, and we can't have that in a fee-for-service environment where you're cranking through 20 to 30 minute encounters. But those incentives are going to be realigned over time, and we talked about that on our last podcast. But just in terms of creating the relationship, it comes down to, I think, dispersing leadership in a way that maybe physicians haven't been trained in medical school, how to provide care in an interdisciplinary way, where you're no longer the cowboy or the autocrat, delivering care and calling the shots, but you're really part of the quarterback. You're facilitating handoffs. Those handoffs are with other people on the care team that are fully empowered up to the top of their scope or licensed, where they can communicate effectively in a linguistically appropriate and culturally competent way. They can provide the information, form the relationships. There's a technology enablement to that as well, in terms of how do you engage those patients in a way that maybe spans the brick and mortar of the facility to create an ongoing communication, and really the delivery system over time evolving, as we talked about last time with the payment model structure. So yeah, I just wanted to kind of get your thoughts on this aspect of relationships in the healthcare setting, and just thinking about information as the ultimate currency of health. How do we foster trust and in building the relationships where they need to be, where that information exchange can happen more readily?
Right. When I think there's, the piece about the patient engagement and the patient engaging with the care team, and what that looks like. And there's many ways in which we can improve on that through even the user journey, the online user journey, in terms of giving access to information that perhaps the patient didn't have before. And now I'll use my own example. So I had ovarian cancer a year ago. I had like the best care within 48 hours of being diagnosed, got in, had the ectomy, and then great care team. Then they sent me home and they said, we'll send your lab work to Johns Hopkins and we need to check on this clear cell. And I go home and I go, clear cell, what's a clear cell? So I start Googling it. And I think about how that took me down a rabbit hole of not really understanding what that meant for me. And as I reflect back on that, I really think that provider, that clinician, that care team could have helped me go to a trusted, reliable website, a URL that helped me understand what a clear cell meant, what stage I might be in. And so there's some really good research out there on online experiences for people. And I'm just going to quote a couple surveys that were done. One was on 2,000 Americans. Their first step, just like I did, put in clear cell, or maybe you put it in something like, I get a stomach ache, I have a stomach ache every day or something, but it's not specific enough. And so having the care team really help guide me to the right URL, or help guide me to being more specific around my conditions. Gee, I have abdominal pain every morning or after I eat meals. But the research shows that half of the people that go online today end up finding something else about themselves that didn't even come to fruition that they had. And so there's a lot of great data out there. We have, online videos are a global phenomenon. But I think clinicians are really in a great position to create the engagement, to direct their patients to other resources for them that are specific and reliable to educate that patient on what that might mean for them, versus just sending them down sort of a general Google search, which may lead them to more concerns around their health that may not even be legitimate. So we have, again, a lot of data. There's 500 hours of content are uploaded to YouTube every minute. And we got 2 billion people that are logged in viewers to YouTube every month. So people are out there, but what can the delivery system and the clinical practice do to tailor their patients' needs more specifically, so the trust is there to say, oh, I need to turn to my care team. And I think the value-based movement, although we may not like that word, the fact that in these arrangements with the government and other purchasers and payers, by understanding our population and being able to reach out to them specifically, we certainly saw data during COVID where we were able to reach out to them because we knew them by their names, create the engagement that is really about meeting them where they're at with their conditions, with additional information. So the activity is not, I need to hop in my car and go to the ER, or I need to hop in my car and go to the, urgent care. I can call. I know it's trusted. It's connected to some devices. I mean, who doesn't know how many hours they slept last night, Eric, right? Who doesn't know their heart rate now? Who doesn't know and monitor their activity? There are wearable devices. Look at Chat GPT. I'm sure you've looked at it, which is an online resource, helps a clinical practice say, this parent that has hypertension, it's 2 a.m. in the morning, to be able to script the narrative of around, I'm a nurse in Baltimore, my patient has hypertension. What are the right words, the right scripting that I can use at that moment to help that patient know what the next steps are that they should take in their care journey? So we've got, again, a lot of data and data being uploaded. How do we decipher what's the right information for our patients? And I think that the clinicians, they undergo years of training and they've learned quickly to locate and process valuable information to discern what is the most appropriate decision or plan of care, where the average person doesn't have that expertise. I didn't know about ClearCell. You didn't know about your piece. So I think this really challenging our notion that we're patient-centric is critical, and it's critical with the lens of information, given how much information is out there, and helping to, improve that appointment, that time that we connect with the patient, and how we use other devices to help them understand what might be going on with them or a member of their family.
Well, Debbie, I love where you're going with this. I mean, you're taking the practice of medicine, which in and of itself is a science, and you're merging it with an art form, that art being communication. And I can't help but think about, your journey that you shared as a patient, but also millions of other people that are going through extreme suffering. They're going through a formidable time of distress, and it's the worst time to take on a torrent of information and make sense out of it, and there's information overload, there's anxiety, there's finding veritability from different sources. Of course, you're going to seek, confirmation bias to figure something out, but, based on what you're reading, which may, take you down a rabbit hole. There's all this complexity of information. It's lacking context. To your point, there's definitely a way to use technology and through patient engagement. There's generative AI that you talked about with ChatGPT and how that can be assimilated into the clinical environment. But I also think about just the artful approach to creating an information exchange that really honors the patient and what they're going through, and curating that information in a way that can be encoded and received in a way to really effectuate change. So I just wanted to see your additional thoughts just on how does the system evolve along with the payment incentives that create that patient centricity to also re-engineer the way it conveys information, where patients can actually make those informed and evidence-based decisions that can really drive appropriate health outcomes.
Yeah, I think that is really an important consideration as we think about transforming the delivery system. How do we realign the payment system where money flows to coaching Debbie on something, coaching that patient on hypertension? Today it rewards the meds, it rewards the surgery, it rewards the office visit, and maybe the counseling that occurs in that fee-for-service environment. I do think, and I mentioned this briefly, I think the value-based care movement and the contracts we hold allow us to reinvest by knowing the population, by tracking the utilization and use rates in those with chronic conditions, as we reward ourselves for improvement in use rates and making healthcare more affordable and in closing gaps in care. We can use those earnings to reinvest in other modes of communication, like AI, like building out care teams, like even what I mentioned in the article, the ProSci change management tool. We need a change management tool really at the delivery system level to engage the patient. Being in that former role of chief population health officer at Essentia in the Midwest, we had a lot of patients with chronic conditions. We just look at our diabetes rates today of over 40 million people having diabetes, type 2 diabetes, and another 1.5 million coming into that chronic population annually. When we touch that patient, engage that patient, I love hearing the story about CVS and how many times they have these connections to patients just through filling the scripts. How do we touch these patients with a thoughtful change management approach? And ProSci has the AdCar model, and we began to use that with our clinicians and administrators, even as we were talking about transforming the clinical practice. And that ADKAR model from awareness. I'm aware that I have diabetes. I have the desire to try to improve my blood pressure, to control my diet, to maybe move a little bit more. The awareness, the desire, the knowledge. I've got the knowledge of what this means. I understand with hypertension and having been a single parent with 2 kids, working 2 jobs, I have kind of the knowledge of what this all means. And then I have the ability and the reinforcement to make these changes in a way that when you integrate that change management with a chronic condition and with a care team that has different ways in which to communicate, to being led by a strong clinical care team that understands the changing behaviors, I think it can be a bit easier. It can be a bit more attractive and a bit more satisfying for the patient to go through this process and actually see some results. I think that's one thing to really think about. I think the other thing that a delivery system or even the pop health teams should think about is really creating a patient advisory council made up of patients in their population or from agencies across different payer types that helps them think about how is the information that I receive as a patient from this system, from this clinician, how does it work? Doesn't work? What's the connectivity? What's the information? How is it given to me to help broaden the perspective of the delivery system to really think that we could do differently than what we do today? Because again, even to the hypertension piece, we have 122 million people that have high blood pressure in this country. We have a big mountain to climb when it comes to chronic conditions, and what we're doing today is not working. So how do we use the online world? How do we use our care teams? How do we take the earnings from value-based care and reinvest it in ways that actually matter to the patient? Because again, if it doesn't motivate the patient to change his or her behavior, then it's not the right information.
Well, Debbie, I love where you're going with system level change, everything from a patient-centered care delivery redesign, value-based care, the ProSci ADKAR model. I'm interested in how that merges with the change that needs to happen at the individual level. I mean, what we're talking about here is really about changing the neural pathways in the brain that drive habit formation and the way we perceive things. I mean, that's the concept of neuroplasticity, where a patient literally has to rewire their brain. They have to consciously create change in their own lives by reorganizing information, things that they've taken at face value for their whole life. They have to assimilate that information and encode it in a way that can be ultimately change deeply ingrained behavior at a human level. And there's a reason why, there's that saying, you can't teach an old dog new tricks. I don't necessarily agree with that. I mean, we've seen evidence and research that you can reverse chronic disease, humans can change behavior, but that behavior change is so difficult. I think about you climbing the mountain. It's a process, and there's pain points along the way, but you somehow have to recalibrate the lens to which you internalize achievement or a goal. You can't just reach the summit in one day on your first attempt. There's progressive and incremental steps along the way. You have to have some goal setting. You have to accumulate those wins over time and create that snowball effect that can create the glide path to long-standing sustainable change that can reverse or ameliorate some of the comorbidities and the overutilization associated with chronic disease. And this is especially challenging, I think, in these low-income communities. I mean, we're talking about where you have a proliferation of chronic disease where if we're looking at the traditional social determinants of health, I mean, these people might not have access to stable, reliable housing. They might not have a grocery store with access to healthy food. There aren't facilities for mental health and wellness that might not exist, or they're certainly not financially accessible. And when you have a treatment plan with underserved populations, it's so challenging to achieve that compliance, especially in the old model, or the current model, I guess, of healthcare, where it's real fragmented. But assuming all that coalesces together towards a population health model, I'd love to get your perspective on where do we go with behavior change and patient activation in this new era of information sharing, especially for those in underserved populations? How can we best reach them where they are in the communities to catalyze the change that's needed to create a better healthcare system and ultimately population health in the long run?
I mean, that is such a great question. Do we have 2 days? So the role of the individual is what you asked about first. I do think that the role of the individual is really important. And I was leading a panel discussion at the National Association of ACOs in October, and 3 of the panelists were physicians, and one was the medical lead from Google, and another one was a EVP for a large health system on the East Coast, and another physician from another system. And I asked the question, what is the role of the individual? And it varied from the health system side, all the complexities that you raised around social determinants and poverty and education and zip code, that maybe the role of the individual didn't have a role, that we needed to really figure out how to meet them where they're at. And that perspective varied from, you're born into adverse conditions, we understand that, but you're still accountable for your health. You still, at the end of the day, are accountable for your health. And so when you look at what the individual can do, it really is about, understanding where they're at and being supported, whether it's by family or churches or their community or their health system. It's really being supported and having access to really understand what that means. So just think about this. We have, as I mentioned, 40 million people with type 2 diabetes. Every year, we've got another 100 million that are pre-diabetes, and most people don't even know they're pre-diabetes. They don't know that their A1C is at a 7, 8, or 9. They're just on the cusp. And so we know that is preventable. So how do we think about that from a system perspective? How do we think about that from an individual perspective? I think at the individual level, can't solve all the issues, nor that's the intent. It is to sort of make people think about, are we really being patient-centric? Are people really being accountable? And so what I am focusing in on are those that have certain conditions that we know about, that we give them access to better information, that we use tools that perhaps we have not used before in hopes that we can prevent certain chronic conditions from occurring, or at least allowing them and helping them to manage those chronic conditions in an environment where we are screening for social needs and we are working with our community-based partners. So there's an integration of social needs along with the care plan to give that patient a bit more hope than what they had to today. I mean, those that climb mountains and maybe work out at the gym, they're using all those wearable devices and they're tracking information, and they're thinking about lifespan. And there's a new book out now called Outlive, and maybe you've heard about it from Dr. Pete Attia. That's about life and longevity and about lifespan, and about the ability to really understand the importance of sleep, the importance of exercise and diet. And so who becomes the trusted person for that person living in a zip code that has all these complications? I'm not sure I have all the answers, but I do think being on the delivery system side for 30 years, we can do it a lot better than what we have been doing. And we certainly have the ability to redirect resources in a way that supports the clinical care team and has an opportunity to really meet that patient very differently where they are. Because today at 2 a.m., they're going to the urgent care, they're going to the ER. So I think we have a lot of opportunity to just focus on the population that we know and try to improve where they're at with information. So you look at all the health literacy. I mean, the whole health literacy, is a public health problem, and it's prevalent more than we are even aware of. And you think about a time when you or a friend, you received sort of bad health news, like we talked about. The statistics around health literacy is sort of dynamic, and nearly 9 out of 10 adults will have difficulties with health literacy when they are stressed and trying to access information. And half of those adults have limited health literacy. And so there's guidelines out there that all materials for patients should be done at the 5th grade level. So you ask yourself, when you look at the information from a clinical perspective, not from a marketing and communications department, but just from population health and how we take care of a population, are the materials, understandable, readable, actionable, and trustworthy? And I think we've got a lot of opportunity really within health literacy, because without that, we're not necessarily reaching those populations that we should. And we're having, worse health outcomes as a result of beneficiaries not getting the right information. And United Healthcare just had done a study recently where they estimated that nearly $25 billion could be saved if all Medicare beneficiaries had adequate health literacy skills. So there's an opportunity right there.
Well, Debbie, as I think about this, the importance of health literacy, the most powerful environment for that information to be delivered to the patient is in the primary care setting. And I can't help but think about the way that patients currently consume the healthcare system. It's almost like you don't perform routine maintenance on your vehicle. You don't do the necessary oil changes, and then your car breaks down and you take it to the mechanic. And that's kind of what we do in American healthcare often as patients. We wait until we have an exacerbation of chronic disease. We rush to the specialist or the hospital and ED to get care, and we're not really engaging, our primary care providers the way that we should. And I know there's a multitude of different variables that play into that in terms of reimbursement and the shortage of primary care providers. But there's also this debate right now. I'm sure you've seen in the news, over the last year, there was a federal judge in Texas that struck down a provision of Obamacare that seemingly could prevent 151 million people from losing access to free preventative services such as mental health and guidance on weight loss and, getting the screenings that people need. And I'm not going to ask you to comment on that, but I'm just thinking in terms of the emphasis of primary care as the arbiter and the vehicle to which we deliver information to those communities and form those partnerships with the churches and CBOs and the patients, the households themselves. Like, how do we somehow maybe change the thinking, of the patient in terms of having that level of accountability to proactively seek primary care before they ultimately have an explosive healthcare crisis?
Right. I think this gets back to education and information, right? Where are they getting the information today? And where are they getting their information today when it comes to their health? So I think there's a multi approach to information and improving on that information for them. I do think that, and we didn't have this at Essentia, I'm not sure how many systems do, but think about how helpful it would be if you truly had a patient advisory council and you had members and it was a diverse in race and ethnicity and payer type, and you educated them about the use of telehealth and maybe the importance of annual wellness visits. And you talked about MyChart or the patient portal design, or you talked about the importance of prescription refill reminders, helping. I think it's, anything we do, we have to start off small to really understand the problem we're trying to solve in the communities, and every community is different. So tapping into the CBOs and communities, they're different. And I think as much as we need to do that work and engage people to say, is this motivating us or not? We've got to learn, course correct, and transform. I think the other thing that we don't talk enough about, and that's really the role of the public health system and, in addressing ongoing and future healthcare issues and crises and equity and earning trust. We've got the 10th Amendment, right? We've got the 10th Amendment of the Constitution that delegates public health powers to the states. What's the role of, and not to divert it from the health system, because we all have pieces that are important to us because we're accountable for something. And I'm talking about improving on where we are today. But what is the role in creating a building on a public health system that really does address these issues and works in the communities through the health departments? I mean, we saw a bit of that with COVID, and I'm not sure we're any more prepared as a country to deal with the next pandemic. I don't think we've got the right structure. I don't think we have the right funding. I think there's just too many silos to figure out how to engage. What is the role of the public health system when it comes to social needs, social determinants, information, and coordinating that across agencies within a community where a health system and a population of people, individuals, citizens need to be served?
Well, Debbie, you bring up some great points. And, I was thinking about this responsibility for information in the context of the healthcare environment. And we've talked about providers and the delivery system. We've talked about the individual patients, but there's also, I think, this role of government. And, certainly in creating these patient-centered models, there's a lot of focus on value-based payment. How do we reduce healthcare costs and improve quality of life, have better outcomes, reduce disparities? But there's also this aspect of information. And as I was thinking about it, as you were talking, this flow of information that can empower personal health and well-being, it has a cascading effect that it's intergenerational in terms of the impact it has on families. It can build social cohesion and stability. It can create long-term sustainability for our country. It helps us be more globally competitive in a marketplace as a country. There's a dividend that's paid, by a healthy, well-educated population that takes accountability for their health. Just curious as to where you think we could have CMS or CMMI look at beneficiary engagement, and maybe this comes with the patient-centered types of models that you're describing, but, how do we become better equipped to face the challenges and opportunities of the modern world by unleashing and empowering patients with information, knowing that the government is really driving a lot of what happens in our healthcare delivery environment?
Yeah, that's another great perspective on this. What is the role of government? And I've been a free market gal, but I look at what John Bloom and Liz Fowler and Mima Shashami are doing at the CMS level. And they recognize they control 160 million lives in this country with Medicare, Medicaid, the duals, and the individual market. And there's a lot of discussion around multi-payer alignment. There's a lot of discussion around administrative simplification and looking at how many quality metrics in these different plans do we have. They spend a lot of time, and I was in Orlando last week at NCQA's conference, and the week before, or 2 weeks before at NACO's, and listening to them talk. And they have been on tour looking at the 10, regional offices across the country, meeting with ACOs, and ACOs represent about 13 million lives. The MA plans represent obviously about half of the 65 million. 30 million that are part of the Medicare population today. And I think that they're seeing and learning more about underserved areas. So you talk about information just hard to reach underserved populations and what their role is. Some of the things that they talk about are just the pressures of information that the Cures Act was designed where clinicians that would receive information from the hospital and discharge information about Debbie and getting that information back to the primary care physician so the coordination of care can occur. And we know that coordinated care is better care and less costly care because you don't have to duplicate a lot of those services. And so, they talked about San Francisco, Puerto Rico, Alaska, Kansas City, difficulty in getting access to services, and patients with ESRD, having the highest mortalities, and the physicians and telehealth. And they were touching on all of these pieces that create accountabilities for hard to reach populations, that address workforce, that talk about realignment of payment so providers can be paid more in underserved areas because the services are not at the level that you might find in an urban area. And oh, by the way, half of this country is in an urban setting. So I think they have their pulse on what's happening in the field. And they also have their ability to say, we represent a lot of lives and we're here to save the Medicare Trust Fund. This is not about an ROI and shareholder return. It's the Medicare Trust Fund. It's state budgets. And I think they're looking at ways to simplify things for the providers, realign payment, and the focus on equity, that you can't talk about quality if you're not talking about equity. And so I think they're committed to, transformation. What does that mean for information? I think that they're not going to tell their 450 ACOs what to do. They're going to highlight the issues and know that that transformation happens in those clinical settings, but they're going to support the system to improve care for their beneficiaries. And they're consistent about that. And so I do think that they are uniquely positioned to take this federal framework, work at the state level, work at the federal level, and make kind of the changes to simplify things for us and to identify those areas where providers are still not being accountable for giving information to the right primary care level so care can be better coordinated. I think we're going to see more from CMS, is sort of the bottom line that I'm speaking to Eric.
Well, Debbie, I definitely agree and share in the optimism there. We talked about earlier just the redesign of the clinical environment. The clinicians have to adapt themselves. They have to train their staff. They have to engage on this new concept of building patient-centered relationships and building health literacy. There's a tech enablement component to it, looking at AI and chat tools. There obviously is a culturally appropriate and inclusive aspect of health literacy that comes about through culturally competent care, which improves health equity. And earlier you referenced a powerful model for change management called the Pro-C ADKAR model. I must be honest, I don't know a lot about it. I know the acronym: awareness, desire, knowledge, ability, reinforcement. It's about changing patient behaviors and requiring that individual change. But, I just wanted to ask you if you could maybe talk a little bit about that model and how our listeners might be able to incorporate that in what they do.
Yeah, so just go to Pro-Sci, PROSCI, and ADKAR is an acronym, ADKAR. It's a powerful model for change management. And I think when it's applied in healthcare, we can see results that get to the individual level. So when we use that at Essentia, we actually started with the clinicians, the whole concept of why value-based care, why being a high-performing clinician is important. And we went through many conversations with our clinicians around what it means to be a high-value, high-performing clinician. And we did things, so it was awareness of what is an ACO, what is value-based care, what does it mean to deliver high-value care, which means what does it mean to deliver wasteful care, unnecessary surgeries on people with BMI over 45, doing additional tests and doing additional imaging that's unnecessary. And we got to the level with the clinician that said, I got this order for lab. If I do this procedure, this lab procedure, will I have any more information than I have today? And if it doesn't give me any more incremental information, then I shouldn't do it. So it was the awareness of what that meant, and then creating the desire for the clinician to stop the process, to say, send this procedure back to we don't need to do this lab work. We don't need to do this, MRI, CT, whatever it might be, which led to a lot of conversations, Eric, where the doctors said, well, but if we don't do this surgery, then they're just going to go down the street and get their knee surgery done there. And we said, that's okay. Because to be a high-performing physician, this is what we stand for. These are the clinical protocols. This is the underbelly of how we govern the clinical practice. So we have to let patients go that we would say no to in terms of clinical guidelines. So the ADKAR model started with our clinicians, getting them thinking about transformation. And what I'm suggesting is we take that to the care team and we think through what it matters to the patient, the awareness they have around hypertension, the desire that they have to change or not change. Maybe they're just way too busy to even think about a second blood pressure. And then do they have the right knowledge to understand, wow, I might not be here in 2 years for my kids if in fact I don't take care of this issue. And then really supporting them that they have the ability, they're in the right environment to make that change, and it gets reinforced through the care team. So I'm talking about bringing that change management model down to the level where it's patient-centric and really creating that motivation, that desire to say, I want to be here for my kids. And yeah, I know that I've got other issues, but those issues, I'm going to partner and trust that the system that I'm in, that I'm empaneled to, is going to help me work through these issues. It's an iterative care process.
Well, Debbie, I've really enjoyed our conversation today, and I have one more question for you, and it's more about just the future state of all this, assuming we reach this idealized scenario where there's a perfect convergence of value-based payment, aligned incentives, patient-centered care delivery, the enablement of technology, and then personal accountability and effectuating behavior change at an individual level. There's a lot of people talking about the promise of precision medicine as we learn more about human social genomics and being able to incorporate technology and genomics and understanding, person's behaviors and environment and creating really sophisticated models that can focus on preventing disease before it starts. And it's like precision health at that individual level that really complements the community health that's conducted at the group level. And, I know this is kind of out there in terms of a lot of what groups are doing now, but I'd love to get your take on just maybe some of your thoughts in terms of, how we might be able to incorporate more precision medicine in terms of delivering individual based information to really guide improved health outcomes in the future.
Yeah, I think that's what I'm talking about. I think when I'm talking about, the delivery system and the clinician, it is more intentionality, it is more focused. It's bringing all tools and knowledge and care and humanity and respect and trust to the individual because we know their names. In the value-based movement, in the ACO movement, we know the names of the 30,000 members that we're privileged to serve. Are we treating them only at the highest acuity level with chronic care, or are we addressing them around wellness? Again, it's a sick care system. So what's the roadmap? I guess, Eric, let's talk about the roadmap on a future podcast or with others. What do we have to do to make wellness part of this roadmap? And how long does that take for us to move from really wellness and prevention versus chronic conditions and managing the diseases? I think that's what I'm trying to say. Now, I'm not talking about genome and genes, and I think that piece is important, but I think there's a lot more we can do that we're not focused on because we've not really aligned the work that's truly patient-centric.
I love where you're going with this, Debbie, and it's just always a pleasure to be with you. And do you have any parting thoughts, for our listeners out there in terms of some takeaways that they can implement today to create this improved information sharing environment to improve individual health outcomes?
Well, I think that if you are in a health system today and you have these contracts where you know your patients, think through that population that you're serving. What do you know about them today? And when you think about how you do your outreach and communicate, you think about the rising risk in those with chronic conditions or those that are expensive. And, we typically put them in 4 quadrants in terms of understanding the population. Are your communication, ways in which you communicate and connect your patients, are they effective? Are you using text versus email because no one's paying attention to email? How are you engaging them in a way that they trust you? What are you doing with tools and resources? And how are you supporting the online patient journey, not the user journey, but the patient journey? That once they're diagnosed with something, once they have the surgery, What's the transition to the next level of care? Those are significant fragmented gaps. We know discharge planning. Basically, we get like an D to an F on discharge planning. I mean, we do well when you're in the system, but when we discharge you to home, to skilled nursing, or back to the clinical practice, those transitions, really understanding them. And then I think you can put together a patient advisory council, a patient advisory team made up of who your population is that you're serving and the community, and really have somebody give you a third view of, is what you're doing effective? Is it working? And is it moving the needle? We need to really be, again, the patient needs to be top, and we can't, and sometimes it's difficult because systems have financial issues, and then we cut back on resources, we cut back on what we do. So I think investing and engaging in change management tools and lifestyle changes takes a lot of effort on behalf of the clinician, the patient, and the health system. But the impact of having information that is better, that accessible, that's credible, scientifically based, culturally appropriate, and motivates change can have a profound impact on one's health. And that's what I'm talking about. And I think there's some easy steps for people to think through when it comes to information. And is it motivating patients? Ask them.
Well, there's a lot of great information here, no pun intended. This has been an incredible conversation, Debbie. It's always a pleasure being with you. And I wanted to thank you again for joining us this week on the Race to Value.
Yeah, thanks. It's so good to be with you, Eric. And we'll talk soon.
Look forward to it. Thanks again.